Okay, we're at the respiratory system now. So I just first of all want to give you a big overview. Try to anyway. So the respiratory system moves air from the atmosphere, right, to be delivered to cells. Okay, that's kind of a big task actually. And the way we do it is we breathe air in, right? We breathe air. The air, by the way, is about what, 19% oxygen. So, it's not pure oxygen. So we go in through nose or mouth. Yes. Better to go through your nose because it gets conditioned and warmed or cooled. You can scan for pathogens. In your mouth, you don't have the same, it's a different pathway. So these are going to go into the pharynx. That's the back of your throat. Then that's going to go into your trachea. Right? And that's going to pass your larynx. Well, actually, it's the larynx first and the trachea. Sorry. This is your voice box. Larynx first, then trachea. Then it's going to go into. So if this is your nose, it's got the pharynx behind it. Then you have the trachea, larynx, then trachea, and then that's going to split into left and right. And these are bronchi. These are lungs, right? So the air is going to go in, and it's going to go down these bronchi, which get smaller and smaller and smaller and smaller and smaller and smaller and smaller. And they're finally going to end up at a terminal bronchi, and at the end of it, you have all of these circles. These are called alveoli, and they look like grapes. And around the alveoli, there are tons of capillaries, right? And these capillaries are going to pick up oxygen and take them back to the heart. Okay, so we're breathing air in. It's going to go down these tubes. It's going to go into these alveoli, deliver the oxygen, and its job is done. As it breathes out, it's going to carry carbon dioxide. That's going to go out your nose. Job done. So it's kind of a simple system, but it has a lot of moving parts. So we're going to get into those moving parts. So the functions, of course, is to bring oxygen to the cells because it's required for metabolism. It also releases carbon dioxide, which is one of the byproducts of metabolism. So there are 4 processes involved. You need to know these. Pulmonary ventilation, that's just the movement in and out of this system that I just told you about. It's just ventilation just means you're moving the air in and out. That's what's called pulmonary ventilation. External respiration is gas exchange in the lungs. External refers to outside of the cells. This is gas exchange in the lungs. So O2 in and CO2 out. Transport of respiratory gases. That's blood to cells. Then internal respiration is the actual physiological process of O2 going into cell. Okay? And CO2 leaving the cell. That's it. Okay, so we have organs that are specialized to handle this task. And these are our respiratory organs. The nose you're familiar with, the nasal cavity, paranasal sinuses, the pharynx, the larynx, the trachea, the bronchi, and there's primary, secondary, tertiary, and terminal bronchioles. The lungs and the alveoli, that's it. So it's 1, 2, 3, 4, 5, 6, 7, 8, 9. The bronchi is a tree. Here's a trachea that goes in the left and right bronchi. These will divide and 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 divide down to a terminal bronchiole, which is teeny weeny weeny weeny, and then the alveoli. Ta-da-ta-da. That's it. So this is really just one thing. The primary is this one, the secondary is this one, the tertiary is that one, and it goes on and on and on and on and on until you get to the terminal. Okay? Very simple. So here we go. Here's a picture of that whole jazz. Here's the nasal cavity. All of this is the nasal cavity, superior, middle, inferior concha. Here are the nostrils. Here's the air comes in and it's going to go in here. The pharynx is all of this area right here. So this is the nasopharynx, this is the oropharynx, and this is the laryngopharynx. So it's naso because it's behind the nose. This is oro because it's behind the mouth, and this is laryngeal because it's close to, I think it's actually a laryngeal YL. Okay? This is the larynx or the voice box right here, just between here and here. That's a specialized structure we're going to learn about. We're going to learn about this, and then we're going to learn about this and this, etc. And then, of course, you have the mouth. So, this is the trachea. These are the right and left main bronchi, or primary bronchi. Here are the lungs. And, of course, the diaphragm below is going to be the part of the bellows, which is going to push air and pull air. So we have two divisions. They're called the conducting zone and the respiratory zone. This is simply for moving air. It's a pipe moving air. The respiratory zone is where oxygen actually enters the blood. The nose. Okay, this provides an airway, obviously. It moistens and warms the air. Very, very important. It filters the air. Very important. A resonating chamber for speech, that's just nice. And it holds the olfactory receptors. The other thing it does is that it exposes air to mucous membrane, which has macrophages in it, to immune system. Okay? Embedded in mucous membrane. Important stuff. So, the size and shape of your nose has to do with all these different cartilages. You need not know the names of these cartilages. They're different too. And this is hyaline cartilage and this is dense fibrous connective tissue. Very strange. Don't care that you know about that. Don't know about that. You know the maxillary bone. Septal don't need to know that. You know the nasal bone and you know the frontal bone. I don't care that you know the names of these. This bone can be broken and reshapen when a person has a nose job, but usually it's the shape of these that people want to change. So what they do is they just make a cut on the underside in here. They pull out these cartilages, they whittle them down, or they make it bigger, and they can reshape, put it right back in, and it reshapes your nose. It's very strange. Okay, so the holes in your nose are called nares. Those are your nostrils. There's a septum. Septum means wall. So you have a left and a right nostril. Just feel the septum in the middle. It is continuous from your nostrils back into your nasopharynx. And you don't need to know that. We have two types of mucous membrane. One is for smelling and one is for respiration. The epithelium is pseudostratified ciliated columnar. So here we go. Here's a little more detailed picture. Here's the nostril here. Here's the nasal cavity. This is the passageway into the pharynx. Posterior nasal aperture. Aperture just means doorway. Here's the superior middle nasal concha we've already talked about. Here's your mouth, soft palate, uvula, uvula. Here are your tonsils. Here's the epiglottis. This is what covers your trachea or your larynx when you swallow so that food goes down your esophagus instead of down here. Whoops. So there's a common passageway here with food and air air wants to go that way and food wants to go that way. We don't want food down there, so we have this epiglottis which shuts. Okay, so here's the nasopharynx, the oropharynx, and the laryngopharynx. Anteriorly here we have, this is the larynx here, voice box. That's the actual vocal fold. And here's your trachea down here and your esophagus back here. So I don't care that you know the individual names of the tonsils, just that you have tonsils and they surround the back of your throat, and that's hopefully to expose the food to some of this tissue and catch a few pathogens as they come down. But I swallow so quickly I can't imagine how that would happen. Okay, so basically we have pseudostratified ciliated columnar epithelium, and it has copious volumes of goblet cells, and these create mucus, right? Of course, the next layer down is lamina propria, and the cilia move contaminated mucus back down your throat. So we have these inferior middle nasal concha. The purpose of these is to spin air, to expose it to the mucosal lining so the dust will get stuck to it, and then it'll get, with the cilia, will push it down your throat. That's all it is. Okay, these are the sinuses. You don't need to know them, but I want you to be aware of them when you get an ice cream headache. This is being squeezed, and that's what that pain comes from. These are the sinuses that get infected when you have a cold or an allergy or things like that. And they do have tiny holes so that they're supposed to remain pressurized. The air in here can be one temperature, and the air outside can be a lot warmer or cooler, and that can expand or contract the air in there, causing pain. So we have small holes that sort of equalizes the temperature and the pressure. But if those get clogged up, then this can cause a lot of pressure and cause a lot of pain. So the pharynx is just the passageway at the back of your nose, mouth, and a little bit lower. And it's just a common passageway for air and food. Again, naso, oro, and laryngeo. And as we go down, the type of mucosal lining changes because they have different purposes. The nasopharynx is going to have a lot of mucus, and only air goes down that, so it doesn't have to have the same type of protection as the oropharynx, which has to have a lot of simple squamous, or stratified squamous, because there's a lot of rough stuff that goes down your throat. Well, this will be columnar, pseudostratified ciliated columnar. This will be some stratified squamous, and then we're going to go back to columnar. So again, the nasopharynx, you know where it is. The oropharynx is the back of your mouth, and the laryngopharynx, we're going to go back. Okay, we're going to stay with simplified or stratified squamous until we get to the larynx. And the larynx has three functions. One is voice production, one is an airway, and it routes food and air into the proper channels. So the superior opening is closed during swallowing and open during breathing, and the epiglottis is the doorway. It's the doorman, so to speak. So it'll divide what's coming in between the trachea and the esophagus. If I repeat stuff, it's because it's important. So we have 9 cartilages in our larynx. Larynx is the voice box. We have this big thyroid cartilage. That's the Adam's apple. It's the largest cartilage. And then we have these 3 pair of smaller cartilages: arytenoid, corniculate, and cuneiform. I know these have they mean something in Greek, but I'm not sure what they are. Then we have the epiglottis, which I've spoken of before. We have vocal ligaments in the larynx, and these help us to strain the vocal cords or pull them tighter or looser so that we have high-pitched voices and low-pitched voices, sounds. Okay? The epithelium of the larynx is stratified squamous. And then as it gets lower, it's going to be pseudostratified ciliated columnar. So here we go. Here's the epiglottis. It's posterior. Here's the hyoid bone you're familiar with. This is the thyrohyoid membrane because it's between the thyroid cartilage. And it's called thyroid cartilage because the thyroid gland sits right here, both sides. Okay, and it has an isthmus across the middle. So thyrohyoid membrane is the membrane between the thyroid cartilage and the hyoid bone. So that makes sense. This is your thyroid cartilage here. The cricothyroid ligament is this right here. This is the cricoid cartilage. So this is the cricoid cartilage here. So this is the cricothyroid ligament. So it's named for the crico and the thyroid. So down here we have tracheal cartilages, which are not circular all the way around. They're C-shaped. And on the posterior side, it's just soft tissue because the esophagus is back there. So, well, we'll see a different view of that. Okay. So, if we take this view, anterior, posterior, so we're looking from the underside upward. Here's our cricocartilage here. Here's the thyroid cartilage here. Here are the vocal ligaments. This is where air will be pushed through. These will vibrate and they make sound. So the arytenoid cartilage, of which we spoke prior, and the corniculate cartilages, these create a lever so that when muscles are attached, these muscles here will pull and it'll tighten this ligament so you make a higher voice, or this will relax and make a lower voice, lower sound. So this is the arytenoid and this is the corniculate. They look different on different views. If you look into someone's throat, here's the base of the tongue, here's the epiglottis, here's like a false vocal cord and the true vocal cords. The actual spot where they close is called the rima glottis, which is just ridiculous and I would never ask you. Here's the corniculate cartilage. So it's easier to see on a different view, which I don't have. No way. Really? Wow. Okay. Oh, I need one more view. I'll try to get that for you. We need one more view of this. Okay, so here's the arytenoid and the corniculate, and we need the cuneiform. So I need to show you one more view so we get the cuneiform. Okay, I'll get it for you. Okay, so voice production. The length of the vocal cord changes and they get tighter. So the closer they are together and the tighter it is, the higher the pitch. And the lower, the more lax they are, the lower the pitch. So, there's also a sphincter function of the larynx called the Valsalva maneuver, which happens when you're straining. So if something goes down there and you push real hard, that can push right through, like the Valsalva maneuver. It's like, when you come up behind someone and you push on their abdomen, and if something had gone down their windpipe, it pushes it out. The innervation of the larynx, very, very important. It's called the recurrent laryngeal nerve, and it's a branch of the vagus. So the vagus nerve comes down into your abdomen, and then it comes back up to your throat. So that's why it's called recurrent. It goes down, and then it comes back up. This is important because in any surgery of the neck, this has to be located first, this nerve, so that it doesn't accidentally get cut and leave you voiceless. So it's very, very important that you're aware of that, so that if you or someone you love ever has surgery in their neck, you can ask the surgeon to make you feel better by understanding that they're going to look for that nerve and preserve that nerve. So the trachea, this will descend into the mediastinum, right? It has these C-shaped cartilage rings which keeps the airway open. And then the carina is the area where they split into the bronchi. So this area right here is called the carina. They have to call it something, so it's called carina. And now we're into pseudostratified ciliated again. So here's a ring around the anterior portion of the trachea, right? But posteriorly, it's soft because the esophagus is here, and if something large goes down the esophagus and stretches the esophagus, it has somewhere to push. So if this was solid cartilage, it would constrict the esophagus and you might choke. And not choke, but the food would have a hard time going down. So I don't care that you don't need to know that. This is mucous membrane. We already know that. This adventitia, this is going to be on the outside, right, of the trachea. The inside of the trachea is going to be epithelial tissue. Out here is just adventitia, which is just connective tissue. So the bronchial tree, very simple, comes down like this, right? And it looks just like a tree inverted. So the trunk, which is the trachea, will have two main branches, right? And then it's going to, on the left, it's going to have two branches, and on the right it's going to have three, because we have three lobes on the right and two lobes on the left. So 3 lobes here and 2 lobes over here. So here's your primary or main bronchus. Here's your secondary. So you have 2 secondaries on the left side. And you're going to have 3 on the right side. 1, 2, 3. This is your main bronchus here. And your 1, 2, 3 secondary. These will be tertiaries out here. So this will be tertiary, 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 tertiary. And then they're going to branch and branch and branch and branch and branch and branch and branch until you get to the terminal bronchi, right? And those will be connected to the alveoli. So this is pretty simple stuff. Remember, this is called the carina right here. Carina. Carina. Okay, so you know how these go. So the changes in the tissue composition along the conducting pathways. So once we get past the C-shaped cartilages and we're into the bronchi now, the epithelium, which was pseudostratified ciliated columnar, will be simple columnar, then simple cuboidal as it gets out into the distal bronchioles. So smooth muscle starts surrounding the smaller bronchioles, and that's where you get the asthma stuff. Those constrict and air can't move. So the respiratory zone, this consists of air exchanging structures. So we do have respiratory bronchioles, and they branch from terminal bronchioles. So if you have a terminal bronchiole, air exchange can actually happen there. Then you're going to have your alveoli here, right? So all of this has a lot of capillary action. So anywhere there's a capillary and a very thin structure, you can get gas exchange. So this is terminal bronchiole, and these are alveoli. And there are holes between each of these alveoli into the other ones, so that one breath of air can fill up all these alveoli. So here's a terminal bronchiole right here. And now this is respiratory bronchiole here. So gas exchange can happen here and in the alveoli. It's just far more efficient in the alveoli. So they're clusters of these, small sacs. And again, we have these holes with, this is going to have an alveoli stuck to it. And then we have these pores stuck to other alveoli. So the alveoli have type 1 cells and a basal lamina. So this is going to be single-celled endothelial, right? Endothelial. Simple squamous. Scattered among those type 1 cells, which is just the simple squamous, are cuboidal epithelial cells, and these are type 2, and these have a different function. These secrete surfactant, and surfactant is very similar to soap. If you'll notice, when you wash dishes in a sink, you get a lot of bubbles on the surface here, right? Well, those bubbles, the surface tension on the bubbles allows them to stay as a bubble. If you touch it, you break that seal and it pops, right? So that's called surfactant. And we have this in our lungs, and it keeps the alveoli open because an alveoli has only the thickness of a soap bubble. So very important, that's always a test question. Type 1 is always a test question. That's just a simple squamous cell. And the type 2 cells are a cuboidal epithelial cells which secretes surfactant. Okay, so this is what they look like. So here's the arterial side of the arterial side of the capillary, and there's the venous side. This is an alveolus, that's one alveoli. This is a bunch of alveoli. And we have elastic fibers there too, because they will expand and contract as you breathe. They'll get bigger and smaller, bigger and smaller. So you need some elastic fibers there to return them to their original shape. So now we're inside of an alveoli. Here are the pores to the other alveoli and the terminal bronchiole, the respiratory bronchiole. Here's a cross section inside a capillary. Here's a macrophage. And here's a type 2 surfactant cell. So these green ones with the hairy surface, that's surfactant, and that will coat the inside of this alveoli and keep it open. So these that are more star-shaped, these are macrophages, and they're going to kill any bad guys that they see. And here's the alveoli, here's the capillary, here's the basement membrane. And that just allows for free diffusion back and forth. Okay? So that's it. The alveoli have elastic fibers, so they return to their shape. When you're breathing out, they're this big, and when you breathe in, they're this big. and the elastic helps return it to its regular shape. Okay, now we're going to talk about the lungs. Da-da-da-da, we're going into the lungs. Each lung has this parietal and visceral pleura. You've heard of pleura and pleurisy. This is, again, the serosal membrane. Serosal membranes have a parietal and visceral layer with, serous fluid in the middle. And this, again, decreases friction. The pleural cavity is surrounded by the pleura, and there's a potential space between the visceral and parietal pleura. That means there is not really a space, it's a potential space, which means you could get an infection between these two layers, and then that space would get larger and fill up with fluid. The pleura help divide the thoracic cavity from the lungs, and it helps sequester the lungs so that there's any infection, it can't travel to the rest, like your heart or any other structures in your thorax. It divides the mediastinum and the lung compartments. So these are the layers of the pleura here, the two red layers here. Here's the visceral pleura and the parietal pleura. Here's the hilum of the lung, it's where the vessels come in and out, and the diaphragm inferiorly. So here's your lung here, the pleura, the parietal and visceral pleura. So the lungs only come down, right, this far. I don't know what you would call that, because, the ribs start up here and they come around here. So maybe they talk about it from this level. So this would be rib 6. Right? 8 on the outside, 6 on the inside. Anyway, just below the xiphoid process, I would say. So it doesn't cut, the lungs don't go all the way down to the bottom of your rib cage, is what I'm trying to point out on this slide. So landmarks of the lungs, we have the apex, the base. The apex is at the top, base is at the bottom. The hilum, that's where the stuff comes in and out. And the root is the same as the hilum. The left lung has 2 lobes, superior and inferior. And then it has a fissure, which is the space between the two. And it's at an oblique angle. You have to see a picture to really appreciate it. The right lung has 3 lobes, superior, middle, and inferior. So this is superior, middle, inferior, superior, inferior, and this oblique fissure goes sort of like this. So it goes obliquely from here to here, anterior to posterior. I don't care that you know the names of the fissures at all. Okay? Diaphragm down here. Also, this is the base of the lung. This is the apex of the lung. The hilum is where all the bronchi and arteries and veins come in and out. So this, I want you to see that there are divisions in the lobes, but you don't need to know these at all. Again, these are where the different bronchi goes into the different lobes. And a pulmonologist would need to know each one of these, because he could take a bronchoscope down here and he could understand exactly which bronchi he's going down, and he'll go down this one and he'll go down this one, and he'll look for tumors and fluids and infections. He'll go down each one of these. And then you can also have it's called like a bronchial lavage. If you have fluid in your lungs, they can remove it by taking a tube and going down each of these bronchi and sucking them out. So it's good clinically, but you don't need to know it at this point. Pulmonary arteries and veins, you know everything about. And this is where they are right here, your pulmonary arteries coming in, your pulmonary vein coming out. And they branch, and they're going to surround, create capillaries around all the alveoli. So Pulmonary ventilation. Inspiration is inhalation. Expiration is exhalation. Well, you know what I mean. The volume of the thoracic cavity increases, and that will decrease the internal pressure in your thoracic cavity. This will automatically suck air in because now the decrease of pressure in your lungs is lower than the pressure in the atmosphere. So remember, diffusion, high concentration to low concentration. That goes for pressures as well. So the high atmospheric pressure will swoop into the low atmospheric pressure in your lungs when you increase that area, or when your diaphragm flattens, it makes more space for your lung tissue, stretches them out. It's a larger area, so it lowers the pressure. Okay, so the intercostal muscles of your rib cage, those will expand. Again, if you make the area bigger, the pressure goes down, it sucks air in. And the reverse is the reverse. You can also use your scaling muscles. These are at the tops of rib 1 to pull your rib cage superior wards. These are, if you have a lot of trouble breathing, you'll see people straining their neck to get more air in. The sternocleidomastoid helps. The pectoralis majors help. You don't need to know all this. Any muscle attached to your rib cage can help expand or contract the muscles around that rib cage to make it bigger or smaller. So quiet expiration is just a passive process. Once you let go of all those muscles, it makes the thoracic cavity smaller, so that it will increase the pressure in there. So now that pressure is higher than the outside pressure, and air will leave. Okay, so forced expiration is when you consciously, active means conscious, right? So that's somatic motor. And then you can squeeze air out. So this is called a bucket handle movement. This goes up and down. This will lift the rib cage. That will increase the area, so air will be sucked in, and the opposite is air will be pushed out. So air basically is an active motion, and exhalation is a passive motion. Okay, neural control. Ventral respiratory group in the medulla oblongata. That's it. Ventral respiratory group. This is a group of nuclei in the medulla, and that will keep you breathing. So here it is. Here's your pons, remember. Here's your medulla. Here's your ventral respiratory group. And here's your dorsal respiratory group. This will get instructions from higher up. And this is the command. This will be motor. Right? And this will be autonomic. Okay, the respiratory center in the medulla oblongata generates a baseline respiratory rate in the reticular formation of the medulla oblongata. There are chemoreceptors that are sensitive to rising and falling oxygen levels. That's in your brain and your aorta and your carotid bodies. You don't need to know any of this. It's feedback to the respiratory center, which makes sure that you have enough oxygen in your body at all times. If you don't have enough, then your respirations will increase and you'll start breathing quickly. That has to do with this feedback from your blood basically going to higher centers in your brain, and then that it will tell the lower centers you need to breathe more quickly. So here are all the different innervations. These are chemoreceptors, which will give feedback, which will change your respiratory rate. So some of the disorders we have are asthma. This is an allergic inflammation, hypersensitivity to irritants. Asthma attacks are characterized by contraction of the bronchial smooth muscle. So basically you can breathe air in, but you can't breathe out. Okay? And secretion of mucus in the airways. So that will restrict movement of air in and out. Then we have COPD, which most old people get because you just start losing alveoli, you start losing elasticity, and it's harder to move air in and out. So airflow in and out gets more difficult. It can be caused by obstructive emphysema, and emphysema happens when alveoli start popping, and it's usually because of smoking. So the heat and the toxins just break these. So now you have these big air spaces in your lung instead of a bunch of little ones, so it decreases surface area. So basically you're just not getting enough oxygen into your blood. And chronic bronchitis, inflammation of the bronchioles, that can cause obstructions. So COPD is a functional name, it's not a disease. It's a functional distinction, which means you just can't move air in and out. And it can be because of these two things. It can also be because of asthma. Okay? So you don't want this, you do want this. Emphysema just breaks down your alveoli, and then you lose enough too much. You lose surface area, and you don't pass as much respiratory gas. Now, cystic fibrosis is genetic, so it's inherited. It's an exocrine gland function disrupted. Okay, these lack a specific protein which creates surfactant. So, no, this isn't. No, this is a different one. Sorry. This one, cystic fibrosis, this is an oversecretion of mucus, which has this viscosity in it from fibers. That's why it's fibrosis. And this will cause stiffening of the, like the distal areas with the alveoli and the respiratory bronchi. And that you start losing the capacity to pass gas into the bloodstream. So this is usually fatal. Epistaxis is a nosebleed. Epiglottitis is an inflammation and swelling of the epiglottis. There's one more disease I want to tell you about, but I have to look it up. So two things I have to tell you about. Now, I don't care about this. This is for your information. But the aging of the respiratory system, the number of glands in the nasal mucosa declines, your nose dries out, you get thick mucus, the thoracic wall becomes rigid, lungs lose elasticity, so it's harder to respire, basically. So you expire. No. So oxygen levels in the blood may fall. So that's why you want to stay active so this stuff doesn't become rigid and all dried up. Okay, and that's for that, and I need to get you two more pieces of information, and I'll add those to the website.